Hi everyone, welcome to your online lecture for the course Pathophysiology 2. In today's lecture, we're covering renal and urologic disorders. This slide shows you a list of the different topics that we'll be covering, and urinary tract infections, or UTIs, will be covered in class. This slide reminds you of the normal anatomy of the kidney. Remember that we have the outer region here is the cortex, then we have the medulla, and you can see the different pyramids here, and this is the location throughout here of the nephron, which you would recall as being the functional unit of the kidney. And then when urine is produced, it will end up in these sort of like cup-like structures that are called minor calyces, which join to these major calyces. And then urine will collect here, which is called the renal pelvis. Then it will travel into the ureter, which will, of course, there's two, one for each kidney, which will travel to the bladder. Urine will then fill the bladder, and then urine leaves the bladder through the urethra. Looking here on the right, this shows you the nephron, that functional unit of the kidney. And just to remind you that when blood enters the kidney through the renal artery, it will enter the renal corpuscle, which is this region here, which consists of a glomerulus, which is a capillary network, and Bowman's capsule that surrounds it. So we have blood that enters through the renal artery into the kidney, and it will enter the glomerulus through the afferent arteriole. And substances that are small enough and designed to actually be filtered and pushed through the glomerulus will end up in Bowman's capsule. Anything too large will exit through the efferent arteriole. The substance that's within here, within Bowman's capsule, is called filtrate. It will begin its process of movement through the tubular system. We have the proximal convoluted tubule, the loop of Henle, so we have the descending loop, and we have the ascending loop, and then we have the distal convoluted tubule, and we have the collecting duct, and it's the collecting duct that will eventually, if we move back over here, empty into the renal pelvis and then out through the ureter. And at various different areas of this tubular system, there will be reabsorption of substances that and water that our body needs that we take back. And anything that remains within this tubular system is what we don't need. It becomes part of urine and will exit the body. And so even substances such as water and solutes will be part of our urine when we don't need it, and or will be reabsorbed into our vascular system when we do. So we'll start by talking about urinary tract obstructions. In this image, if we're just thinking of normal anatomy, this shows you the renal artery and the renal vein. Here's your kidney, then here's your ureter, one on each side if you have two kidneys, and then we have the bladder and then the urethra. There are many different causes of obstructions to urine flow, but a urinary tract obstruction is defined as interference of normal urine flow, and this can occur at any site along the urinary tract. And there are various different causes that you can see listed here: kidney stones, prostate enlargement, and bladder cancer. These are the most common that we've listed, and they are squared off here in this image in red. Kidney stones, or the stone formation, is a condition called urolithiasis. And stones are not just necessarily forming within the kidney. There are also such things as bladder stones, but we're really going to be talking about kidney stones in today's lecture. And these stones, when they form, as you can imagine, they can block normal flow of urine. Prostate enlargement we've talked about before, but we spoke about it with more of the correct term being benign prostatic hyperplasia, and this is male anatomy, and you can see the prostate that surrounds the urethra, and when it enlarges, it can put pressure on the urethra, which can end up having the bladder to work harder in order to push urine past that obstruction, and it in itself can undergo hypertrophy. Bladder cancer we'll talk about later today. So cancer of the bladder can also be an obstruction to normal urine flow. Common complications include urinary tract infections, which we'll talk about in class, and UTIs are common when normal urine flow is obstructed, because if urine is retained, it can really favor the development of an infection. Another complication includes hydronephrosis. This is damage to the kidney that we'll talk about briefly on an upcoming slide. And it's really a type of urinary tract dilation caused by an obstruction. So we'll come back to that shortly. We will also come back to this topic here of vesico-ureteral valve reflux. Okay, urolithiasis. This is the formation of stony concretions within the urinary tract, anywhere in the urinary tract. And sometimes you'll hear them called kidney stones or kidney crystals or kidney calculi. And these stones can be classified according to the primary mineral or the salt that comprises the stones. And the most common stone type is calcium oxalate or calcium phosphate. And this makes up about 80% of kidney stones. While the remaining types include magnesium salts, so struvite, and uric acid. If somebody is suffering from kidney stones, it's important to determine why they are suffering from these kidney stones. So it doesn't just mean knowing what the substance is that make up the stone, but rather why the stone formed to begin with. So if the stone is made up of calcium, a common cause or risk factor involves hypercalcemia, which we spoke about last term. So it could be hyperparathyroidism. It could also be bone metastasis, where bone is broken down too quickly, and because of the metastasis, it's broken down, and the calcium ends up being deposited into the blood, leading to hypercalcemia. So too much calcium in the blood then can end up in the kidney, which increases the likelihood of formation of stones. Gout is a disease of nucleic acid metabolism, which can cause the accumulation of uric acid, which, when part of the urine, can form stones. Finally, alkaline urine is also a risk factor for the development of stones. Normally, urine is acidic, but alkalinity can favor the formation of kidney stones. It says here, size determines outcome. You can have a large stone that can remain within the kidney where it can't even move, and it can destroy the kidney. Smaller ones can move to smaller areas. It can move into the ureter. It can even get stuck there. But in any case, these stones can cause pain, and that's really a primary clinical or most important clinical manifestation is pain, which is called renal colic. And the pain is because it's stuck and damage is beginning. And the pain will remain until the kidney stone is eliminated. In some cases, it can move its way slowly but surely through the urinary tract and then be eliminated from the body, but that entire process is quite painful. And the cause of the pain is really there's inflammation, there's damage, there's injury to the area, and that in itself can increase the amount of blood that's found within the urine, which is called hematuria. I briefly mentioned this term on a previous slide that I said we would come back to. There is a condition called vesico-ureteral reflux where urine flows retrograde or backward from the bladder up into the ureters, and it can even, depending on the extent of it, it can continue to back its way up more and more upward through the ureter and even into the kidney. And you can see here that there are different grades that exist. And here with grade 1, you have that reflux, but it's mild. In grade 2, you can see it's backing its way up quite extensively toward the kidney. But with grade 3, what you really start to see happening is this dilation of the walls of the ureter. Grade 4, significantly worse, now starting to impact the kidney itself. And with grade 5, you can see the extent of the damage that has occurred, damaging the kidney, and this is all because of urine retention. Usually this just happens on one side, fortunately, and also fortunately we have two kidneys. Previously I had mentioned that hydronephrosis was a type of urinary tract dilation caused by some sort of obstruction. And there are other types depending on location. So let's have a look at this image over here. If there's some blockage, some sort of obstruction, and the ureter, just so proximal to it, is dilated because of accumulation of urine in this area because it can't pass through, that is called hydroureter. So think of it as fluid within the ureter that's causing dilation in that area. Now, if there is dilation, let's say there's an obstruction higher up toward the renal pelvis and the calyces, then this will lead to what's called hydronephrosis. So it's really the accumulation of fluid more so at the level of the nephron. And so what you end up getting is enlargement of the renal pelvis, the calyces, and areas proximal to that as well. So that's hydronephrosis. One other situation that I'm going to mention is that if there is, let's say there is an obstruction here and we end up with hydroureter, but the fluid, the urine backs up even more up into the kidney, and you end up with dilation of the ureter and dilation of the what is called the pelvic calyceal system. So that includes your renal pelvis and the calyces. So you have the ureter, the renal pelvis, and the calyces that are dilated. This is called ureterohydronephrosis. So uretero, the word would just be before hydronephrosis. Now we'll talk about tumors of the urinary tract. We'll start with bladder cancer, and bladder cancer is the 5th most common cancer. The most common cause of a bladder malignancy is called transitional cell carcinoma, also called urothelial carcinoma, and this is a cancer of the transitional cells. Now, you may remember back to normal anatomy a rather brief discussion on transitional cells. Transitional cells that make up the bladder are cells that are able to transition. They're able to change shape. They're able to stretch in order to accommodate, in this case with the bladder, urine as the bladder fills. So bladder cancer is the primary tumor, meaning that it originated in the bladder, appearing on the inner lining of the bladder, beginning in the mucosa. On the top right, it's important for you to know that this type of cancer begins in situ or in place, and then it can invade the mucosa and the smooth muscle, and it might not even be detected until invasion. On the bottom left here, it shows you different tumor types, and ideally, bladder cancer is going to be found at its in situ stage, but as you can see here, that's only in 3% of cases. Most are papillary, these masses that protrude into the bladder cavity, and if it bleeds, then it can lead to blood in the urine or hematuria, which can indicate cancer. So if somebody has blood in their urine, it's important to rule out infection, obstruction, and always keep in mind the possibility of cancer. And then the person's clinical history is important as well, because there is a strong link to smoking. When we smoke, the carcinogens end up in the bloodstream and move through the kidney and then can sit in the bladder and end up promoting the development of cancer. Chlorine as well, which is found in water used to purify it, is also a carcinogen for transitional cells. So as I said, we're talking here about the primary tumor, so originating in the bladder, but cervical cancer and prostate cancer can metastasize to the bladder, and so then bladder cancer can also be secondary if the tumor originated somewhere else. Patients might also present with other indications that something's going on with the lower urinary tract, such as nocturia, which is excessive urination at night. They might have urgency. Urinary urgency is that sudden urge to urinate. Urge incontinence is involuntary loss of control of urine flow. And finally, this image here is showing you when carcinoma, bladder cancer, goes from an in situ stage and progresses and worsens and invades. The two types of renal tumors that we're going to discuss now are called renal cell carcinoma and nephroblastoma. Just make note now that we're talking about the kidneys, whereas on our previous slide we were talking about the bladder. So starting off with renal cell carcinoma, more commonly inflicts adults and makes up the majority of renal cell tumors. This cancer arises from the epithelial cells of the kidney and is metastatic, so commonly spreads. But the problem with this cancer is only 10% are symptomatic in the early stages. This can make early diagnosis very difficult. In the small percentage of symptomatic individuals, blood might be evident in the urine, and there might be a palpable flank mass. So the practitioner could palpate some sort of mass around the flank region of the individual. Renal cell carcinomas are adenocarcinomas. Etiology, for the most part, unknown. Remember, adenocarcinomas are tumors forming from the glandular structures and epithelial tissue. The second tumor is called nephroblastoma, or Wilms tumor, more common in kids. It's an embryonal tumor of the kidney caused by abnormal proliferation of renal stem cells. It is the most common solid tumor occurring in children. The tumor itself is cancerous, but what's interesting, and you might believe this to be true by looking at this image, is that it's quite well defined and the kidney is still functional, but over time, if it's not treated, it can change and it can metastasize. Now we're going to look at glomerular disorders, so referring to injury to the glomeruli of the kidney. First, we'll talk about glomerular nephritis. Remember, itis refers to inflammation, so this is really inflammation of the glomeruli of the kidney. In these histological pictures, you can see at the top, this is showing you a normal glomeruli, and at the bottom, an inflamed glomeruli, where inflammation and edema is present, and this will induce renal failure because of the inability of the glomerulus to filter the blood or the plasma that comes into it. There are two common causes. One is immune injury, specifically to the glomerulus, so immune glomerular damage. And this is a type 3 hypersensitivity reaction in which immune complexes deposit into the kidney. Another common cause is diabetes, but we'll have a look at this again shortly. So how do we know if someone has this condition? Well, because of what's referred to as nephrotic syndrome. Nephrotic syndrome ends up being evident in this individual's urine. So there's evidence of protein, so proteinuria, protein in the urine, hematuria, blood in the urine, as well as evidence of inflammation. So there's the injury to this area of the kidney will end up damaging the glomerular basement membrane, and it allows then for the passage of blood and protein, or red blood cells and protein, into the urine. So a urinalysis will indicate this. Here we're going to look at the mechanisms of glomerular injury, and the major events that you need to be aware of are highlighted by the red star. Glomerular injury is caused as already mentioned, by immune complexes, so a type 3 hypersensitivity reaction. So when an immune complex forms and circulates, complement is activated, if you remember that from last semester, and this will induce inflammation. In addition, we'll have the proliferation of macrophages and mesangial cells. So mesangial cells are specialized cells that were just briefly introduced to you in normal anatomy, specialized cells in the kidneys that make up what's referred to as the mesangium of the glomerulus. And the primary function of these cells is in itself filtering. So it removes trapped residues and any aggregated protein from the basement membrane, so really keeping the filter free of debris. In addition, the complement activation will lead to neutrophil chemotaxis. Immune complex deposition in the glomeruli will lead to inflammation, or what we know of as glomerulonephritis, and this leads to damage of the basement membrane. So the protein and the red blood cells that normally shouldn't be able to pass through end up being able to pass through the kidney and end up in the tubular system and become a part of the urine, which we can detect through urinalysis. Ultimately, what ends up happening is this reduced glomerular blood flow and glomerular filtration rate, so really affecting how your kidney functions. So our kidney is supposed to be getting a normal flow of blood flow, a normal rate of filtration of the glomeruli in order to keep our body functioning properly. And so the kidney will fail to do what it's supposed to do because of this damage. This slide shows the 3 most common types of glomerular disorders, so diabetic nephropathy, lupus nephritis, and acute post-infectious glomerulonephritis. Starting with diabetes. Diabetes, at least in Canada, is the #1 cause of renal failure. Renal failure happens, as we know from Patho 1, due to damage in the basement membrane of the kidney due to chronic hyperglycemia. Recall that there's increased glycation of glycoproteins throughout the body. Glycoproteins in the basement membrane of the kidney are essential for proper structure and function of the glomerulus. So overglycation or increased glycation is going to promote problems. So the basement membrane will thicken with uncontrolled diabetes, which fibrosis can result, and then it can lead to chronic renal failure. So important for individuals with diabetes to keep their glucose levels in check. Lupus, or systemic lupus erythematosus, or SLE, is an autoimmune disease in which antibodies against nucleic acids are formed. The antibodies will generate these circulating immune complexes that deposit themselves into, for example, the kidney, not just specifically the kidney, but other areas as well. The erythematosus component, or erythema, referring to skin inflammation, it can cause quite a bit of redness in the face. And originally where the term or the word lupus came from is, well, it's Latin. It comes from the Latin word wolf, because these individuals with this condition almost had these facial lesions that were reminiscent of a wolf's bite. And finally, infection from strep throat, but specifically caused by the group A beta hemolytic streptococcus. Of this group, though, this group A beta hemolytic streptococcus, there are specific strains that are considered nephrogenic, and they can lead to glomerulonephritis. Immune complexes here can form and circulate in response to this infection, the strep infection, and can then deposit themselves into the kidney. This slide showing you an image of what diabetic glomerulopathy would look like, and you can see normal glomerulus on the left and diabetic on the right, and here are some stars indicating some major pathological events that you should be aware of. First of all, basement membrane thickening, which we already spoke about. That's obviously going to affect normal glomerular filtration. The next important point is collagen deposition. as damage progresses from the chronic hyperglycemic state, then fibrosis can occur. And sometimes you'll see or hear this referred to as glomerulosclerosis. The glomeruli in these cases are going to be irreversibly destroyed. The glomeruli will be continually lost as this condition worsens and as damage progresses, resulting overall in renal failure if enough glomeruli are lost. Final point is albuminuria, and this relates to protein loss in the urine. So proteins can be lost in the urine when the kidney's damaged, which we know, but we're mentioning albumin here because if you remember, this is a very important plasma protein that contributes to oncotic pressure. Okay, looking collectively at lupus glomerulonephritis and acute post-infectious glomerulonephritis, remember immune complexes are formed, they're deposited in the basement membrane of the glomeruli of the kidney, and this will trigger inflammation. This is diagnosed with a kidney biopsy. So looking here at the bottom, a pathologist will perform immunofluorescence, and so an immune stain to look for antibodies, and when these antibodies are present, it will stain green, in particular from the presence of immunoglobulin G. So in this example, the basement membrane is completely full of these immune complexes. And so in this image, you can see the circulating complexes, immune complexes, and then their deposition. Okay, so we'll move on to nephrotic syndrome. Don't confuse this with the term nephritic syndrome. Nephrotic syndrome is a condition that involves damage to the basement membrane without the glomerular inflammation that we spoke about previously. It's usually idiopathic, and it's more common in children than adults. Now, what changes occur to the glomerular basement membrane then if we're not seeing inflammation? Well, it appears normal. There aren't the immune deposits, but what is seen is uniform diffuse thinning of epithelial foot processes that are called podocytes. Another important feature to mention about this condition that is identified is that there's this loss of negative charge in the glomerular basement membrane. So the negative charge of a glomerular basement membrane would normally repel negatively charged proteins and really stop proteins from crossing the glomerular basement membrane. But with this condition, with this loss of negative charge, we end up with increased permeability to protein. And this can lead to severe proteinuria. We're looking at upwards of anywhere from 3 to 5 or more grams per day. And the primary protein that is seen in the urine is albumin. And so it can be referred to then as macroalbuminuria. So a lot of albumin in the urine. Okay, so that's the major protein. But with this condition, there is little to no hematuria. Okay, there's little to no blood in the urine. These individuals will end up with very excessive edema. And if you think about it, it makes sense because they've lost their albumin present within the blood vessels that would normally keep fluid within the vessels. And so with loss of albumin, the blood vessels have a very difficult time keeping fluid within them. So fluid seeps out. And when fluid seeps out, it goes into the tissues and causes edema. So looking at this term here, nephrotic triad, it includes the excessive loss of protein in the urine, much of which we know is albumin, which ends up leading to hypoalbuminemia. Remember, emia has to do with the blood, and then subsequent edema. This shows you the pathophysiology of what we just spoke about. And so in the red squares, you can see what you need to be aware of, which I already spoke about on the previous slide. So you end up with this change in negative charge, this increase in permeability, which allows for plasma proteins to seep through where they're not supposed to, which leads to excessive protein in the urine, reduced albumin in the blood, an overall reduction in plasma oncotic pressure, which is normal plasma oncotic pressure would keep fluid within the vessels, but when it decreases because of lack of albumin, then fluid is more likely to leave the vessels and end up into the tissue, which will overall also continue to reduce your plasma volume. And this leads to edema. And so these people are going to need proteins given to them in order to help reduce the edema. Now we'll move on to our final topic, which is renal failure. There are two major types of renal failure. We have acute and chronic, so really it's a matter of time. In terms of causes, well, something could go wrong with the kidney itself, and so that's referred to as intrarenal. So a common cause here in terms of intrarenal cause within the kidney is glomerulonephritis, as already discussed. Something could be wrong with the blood supply to the kidney, and so that is called pre-renal blood supply to the kidney. For example, shock. And there could be a problem in the urinary tract really distal to the kidney, such as a urinary tract obstruction. So that's referred to as post-renal. And looking at this image here, you can see the different types. Again, intrinsic or intrarenal, relating to some sort of damage within the kidney, pre-renal relating to blood flow to the kidney, and post-renal is distal, so some sort of obstruction of urine outflow from the kidney. There will then be a pretty obvious and big reduction in glomerular filtration rate, and the kidney failure will be evident in the levels of serum creatinine and urea, which will be high because the kidney isn't properly filtering out these substances. On this slide, you can see the terms pre-renal, intrarenal, and post-renal again. And regardless of whether we have this decreased renal blood flow or some sort of injury within the kidney or an obstruction to urine flow, the end result can be the same, which is oliguria, which is very basically defined as very little urine output. Pre-renal and intrarenal are more common than post-renal because, as you can see with post-renal, it is requiring bilateral obstruction to urine flow, which is it's much more unlikely for it to be bilateral. This slide and the next slide compares acute and chronic renal failure. Really, when we talk about acute renal failure, you can think of it more as being acute renal or acute kidney injury. Now, the cause, let's look at being ischemia, so reduced blood flow, or the presence of nephrotoxins. So these are substances that are toxic to the kidney. So for example, if somebody suffers from massive trauma such as a burn victim would, it will cause the release of myoglobin from muscle into the blood, which can end up at the kidney, and myoglobin is a nephrotoxin. And what this will potentially end up leading to is possible injury to the glomerulus, possible injury to the tubular system, which will ultimately lead to a reduction in glomerular filtration rate, which can then lead to the term we just spoke about, oliguria, which is very low urine output. The good thing about the acute nature of renal failure is that if you correct the problem, whether it's ischemia or the presence of the nephrotoxins, then the effects can be reduced. So urine flow can resume. Now on to chronic renal failure, which is defined as progressive loss of renal function. And there are various different causes of renal failure. You can see systemic arterial hypertension, diabetes, chronic glomerulonephritis, all can lead to progressive loss of renal failure. In terms of renal function, in terms of complications, you can see the terms uremic syndrome, metabolic acidosis, and hypocalcemia, and we'll talk about each very briefly. Uremic syndrome is a very serious complication of chronic kidney disease, and it occurs when urea and other waste products build up in the body because the kidneys are unable to eliminate them. And so this is obviously toxic to the body. It can cause such effects as pericarditis, for example. It can also lead to neurologic damage where seizures and a coma can occur. Metabolic acidosis, since the kidneys can no longer control your acid-base balance, it can lead to metabolic acidosis. You might recall that the tubular cells of the kidney produce bicarb or bicarbonate. And so if the tubular cells are damaged and they can't produce bicarbonate, then acidosis can occur. Also recall that the glomeruli are important in the activation of vitamin D, which is needed for calcium absorption. And so if vitamin D is not activated because the kidneys are damaged, then an individual can suffer from hypocalcemia or low calcium in the blood. Edema can also be an effect, and the reason for that is because your body is not getting rid of excess fluid properly, and so it can build up in the body. And it can also build up in the blood vessels, leading to hypertension, so an increase in blood volume and an increase in blood pressure, which can overwhelm the heart. And anemia, this comes back to another function of the kidney, which is the production of erythropoietin, which is a hormone that stimulates bone marrow to produce blood cells, in particular, in this case, red blood cells that participate in oxygen delivery to the body. And finally, we have a nice summary slide covering much of what we've already talked about when it comes to chronic kidney disease and some of the effects that can be seen. So starting here at the left, on the left, is sodium and water imbalance, and that makes sense because if we're not removing water and sodium, then it's going to remain within our plasma and cause hypertension and increased vascular volume, which could ultimately result in failure of the heart. Potassium balance is also affected. If your body's not eliminating potassium, then you can have a buildup of potassium in your blood, and you might recall that is called hyperkalemia. And that you also might remember can lead to arrhythmias of the heart. Elimination of nitrogenous wastes. If you're not eliminating nitrogenous wastes, then that can build up. So there's that term uremia. Erythropoietin production will be reduced as well because the kidney is damaged. Acid-base balance is affected, as we've already spoken about. Remember, because of that absence of bicarb. Activation of vitamin D isn't going to be able to occur properly if the kidney is damaged, leading to what we already spoke about, referring to the term hypocalcemia. And the parathyroid gland will try to compensate for this, for the hypocalcemia, and parathyroid hormone will take calcium out of the bones and deposit them into blood to try to return the body to homeostasis. So it's really a secondary hyperparathyroidism, and this can lead to osteoporosis if enough excess bone is broken down just to balance out levels of calcium in the blood. Okay, that is the end of today's lecture. Thank you for listening.